Floating water lily sign is feature of lung hydrated. Honeycombing of lung is in chest X-ray is seen in rheumatoid arthritis, tuberculosis, scleroderma, and interstitial lung disease. Ground glass appearance is not seen in left to right shunt. It is seen in hyaline membrane disease, pneumonia, and obstructive TAPVC. Bilateral pleural plaque and pulmonary fibrosis involving bases is hallmark of asbestosis. A 48-year-old man resident of Baroda outskirts near a textile mill presents to his family physician with respiratory symptoms. Doctor advises X-ray chest which showed fine reticular and nodal pattern in lower zone with loss of clarity of diaphragm and cardiac shadow. He also doubts about the presence of small pleural effusion. The probable diagnosis is asbestosis. Extensive pleural thickening and calcification, especially involving the diaphragmatic pleura, are classical features of asbestosis. Solitary nodule lung cannot be lymphoma, it can be tuberculoma, neurofibroma, or bronchogenic carcinoma. Which of the following signs suggest benign nature in the evaluation of solitary pulmonary nodule? Fat density within the lesion. A patient presents with a solitary pulmonary nodule (SPN) on X-ray. The best investigation to come to a diagnosis would be image-guided biopsy. Hypertranslucency of lung unilaterally is seen on all except pneumonectomy. It is seen in pneumothorax, resecting of mammary gland, and pulmonary artery obstruction. Hyperinflation of lung in chest X-ray is seen in congenital lobar emphysema. Hypertranslucent chest X-ray is seen in all except pneumonectomy. It is seen in emphysema. Which of the following is a cause of unilateral hyperlucent lung on chest radiography? Poland syndrome. The cause of a homogeneous opacity on X-ray is all except emphysema. So which are the causes of homogeneous opacity? Pleural effusion, diaphragmatic hernia, and massive consolidation. In lung X-ray, heterogeneous shadow is due to metastatic lesion or tuberculosis. Causes of a cavitating lesion in the chest radiograph are all except hamartoma. So what are the causes of cavitating lesion in the chest radiograph? Pulmonary infarction, squamous carcinoma of the bronchus, and Kaplan syndrome, and hematoma. Miliary mottling is seen in tuberculosis, sarcoidosis, and silicosis. Miliary shadow on chest X-ray is seen in tuberculosis, rheumatoid arthritis, pneumoconiosis, and metastasis. Miliary mottling is found in rheumatoid arthritis, tuberculosis, and pulmonary edema. Miliary shadow in chest X-ray is seen in all except Klebsiella. So it is seen in tuberculosis, sarcoidosis, and metastasis. Miliary mottling on chest X-ray is seen in histoplasmosis, sarcoidosis, and secondaries from carcinoma of colon. Miliary mottling on chest radiograph can be seen in pneumoconiosis, tuberculosis, and mitral stenosis. Eggshell calcification is found in silicosis, sarcoidosis, lymphoma, and tuberculosis. Eggshell calcification is seen in lymphoma, sarcoidosis, and tuberculosis. It is not seen in carcinoma metastatic to lymph node. Mediastinal lymph node calcification is seen in lymphoma and sarcoidosis. Eggshell calcification is seen in all except bronchogenic carcinoma. So eggshell calcification is seen in sarcoidosis, silicosis, and post-irradiation lymphoma. Eggshell calcification is seen in sarcoidosis, silicosis, pneumoconiosis, and lymphoma following radiation treatment. Eggshell calcification is seen in silicosis, sarcoidosis, and histoplasmosis. Eggshell calcification in hilar lymph node is seen in sarcoidosis, histoplasmosis, tuberculosis, and silicosis. Eggshell calcification is seen in sarcoidosis, silicosis, pneumoconiosis, and lymphoma following radiation treatment. Popcorn calcification is characteristically seen in pulmonary hamartoma. Well-defined lesion in the lung with popcorn calcification on X-ray is suggestive of hamartoma. Chest X-ray showing opacity in the lung with irregular calcification is suggestive of hamartoma. Characteristic of benign tumor of lung in X-ray is concentric dense calcification. Features of pneumothorax are all except shift of mediastinum to the same side. So what are the features of pneumothorax? Devoid of lung markings, hypertranslucency, and collapse of ipsilateral lung. All of the following are indirect radiological sign of collapse of lung except loss of aeration. So which are the indirect radiological sign of collapse of lung? Mediastinal displacement, hilar displacement and compensatory hyperinflation. A 55-year-old man who has been on bed rest for the past 10 days complains of breathlessness and chest pain. The chest X-ray is normal. The next step in the investigation should be lung ventilation perfusion scan. Best method to diagnose pulmonary embolism is CT scan. In patient with high clinical suspicion of pulmonary thromboembolism, best investigation would be CT angiography. Gold standard for diagnosing pulmonary embolism is none of these, and if none is not given, then ventilation perfusion scan can be selected. Investigation of choice for pulmonary embolism is contrast CT. Pulmonary embolism is best diagnosed by CT scan. In pulmonary embolism, finding in perfusion scan is perfusion segmental defect and perfusion defect with normal lung scan and radiography and normal chest scan. Hampton hump is a feature of pulmonary embolism. Uremic lung most often results due to pulmonary edema. A young man with pulmonary tuberculosis presents with massive recurrent hemoptysis. For angiographic treatment, which vascular structure should be evaluated first? Bronchial artery. A 40 years old man presents with a recurrent hemoptysis and purulent cough. X-ray was found to be normal. The next investigation done to aid in diagnosis is bronchoscopy. The following is not the differential diagnosis of anterior mediastinal mass neurogenic tumor. So which are the differential diagnoses of anterior mediastinal mass? Teratoma, thymoma and lymphoma. Which among the following is a cause of posterior mediastinal opacity on posterior, anterior and lateral view of chest radiograph? Bogdalec's hernia. Commonest mass in the middle mediastinum is lymph node mass. The most likely diagnosis in a newborn who had a radio-opaque shadow with an air fluid level in the chest, along with hemivertebrae of the sixth thoracic vertebrae on plain X-ray is esophageal duplication cyst. A child has respiratory distress. Chest X-ray shows multiple air-filled space. The differential diagnosis is all except congenital lobar aplasia of lung. So which are the differential diagnosis? Congenital lung cyst, congenital diaphragmatic hernia or congenital adenomatous malformation. A neonate presents with respiratory distress, contralateral mediastinal shift and multiple cystic air-filled lesion in the chest. Most likely the diagnosis is congenital diaphragmatic hernia. Apgar score were 3 and 6 at 1 and 5 minute, 3 at 1 minute and 6 at 5 minute. At 10 minute, child shows features of breathlessness. On chest X-ray, mediastinal shift was there. Possible causes are pneumothorax and congenital diaphragmatic hernia. A child with acute respiratory distress showing hyperinflation of unilateral lung in X-ray is due to foreign body aspiration. Papu, a 2-year-old boy, presents in the casualty with the history of sudden onset of respiratory difficulty and stridor on auscultation. Increased breath sound and wheeze on the right side. The X-ray chest shows RT opaque hemithorax. What will be the diagnosis? Foreign body aspiration. In X-ray, loops of bowel on left side of hemithorax and shift of heart shadow is eventration of diaphragm, foramen of Bogdalek hernia and Morgagni's hernia. A 25-year-old man presented with fever, cough, expectoration and breathlessness for 2 months duration. Contrast enhanced computed tomography of the chest showed bilateral upper lobe fibrotic lesions and mediastinum had enlarged necrotic nodes with peripheral rim enhancement. Which one of the following is the most probable diagnosis? Tuberculosis. A patient suffering from AIDS presents with history of dyspnea and non-productive cough. X-ray shows bilateral perihilar opacities without pleural effusion and lymphadenopathy. Most probable etiological agent is pneumocystis carinii. Centrally located cavitating lesion, lung lesion is most likely to be squamous cell carcinoma. Which of the following organs should always be imaged in a suspected case of bronchogenic carcinoma? Adrenals. Soft tissue mass in chest with rib erosion in X-ray is seen in all except leukemia. So soft tissue mass in chest with rib erosion in X-ray is seen in Ewing sarcoma, multiple myeloma and osteosarcoma. Unilateral elevation of diaphragm is commonly due to large liver or scoliosis. Sequestrated lung is most commonly supplied by ascending aorta. In right-sided hemithorax on chest X-ray PA view, what can be excluded? Congestive cardiac failure can be excluded. It can be tuberculosis, pulmonary infarct. The nodular pattern often seen in the lungs following renal transplantation is thought to be due to cytomegalovirus. Chest X-ray shows opacity after blunt trauma. Most likely the diagnosis is hemothorax. Best imaging modality in bronchogenic carcinoma is computed tomography (CT scan). Investigation of choice for detection and characterization of interstitial lung disease is high resolution CT scan. High resolution computed tomography of the chest is the ideal modality for evaluating interstitial lung disease. Best method to diagnose bronchiectasis is high resolution computed tomography. A 3-year-old female child developed fever, cough, and respiratory distress. On chest X-ray, consolidation is seen in right lower lobe. She improved with antibiotics, but on follow-up at 8 weeks was again found to have increasing consolidation in right lower lobe. Your next investigation would be CT scan of the chest. Chest X-ray of an individual worker exposed to asbestos over 20 years shows an ill-defined rounded opacity in the lower lobe with a comet tail appearance on PA view. Which of the following is the most likely diagnosis? Round atelectasis. Cardiovascular system. In all of the following, increased cardiac cell-out sign is seen except tetralogy of Fallot. So increased cardiac cell-out sign is seen in pericardial effusion, aortic regurgitation, and Epstein anomaly. If the right cardiac cell-out is obliterated, it means the pathology involves right middle lobe. Left cardiac border bulge can be seen in all except enlarged azygos vein. Left cardiac border bulge is seen in left appendicular overgrowth, coronary artery aneurysm, and pericardial defect. Left-sided cardiac bulge seen on chest X-ray is due to enlargement of left atrial appendage. Which among the following is not a chest radiographic feature of left atrial enlargement? Double left heart border. Earliest sign of left atrial enlargement is posterior displacement of esophagus. A patient is having mitral stenosis. His X-ray will show all of the following findings except obliteration of retrosternal shadow on lateral X-ray. So which sign can be seen in the patient having mitral stenosis? Lifting up of the left bronchus, double atrial shadow, and posterior displacement of esophagus on barium swallow. All are radiological feature of mitral stenosis except oligemia of upper lung filled. So features of mitral stenosis are straight left border of heart, pulmonary hemosiderosis, and lifting of left bronchus. Radiological feature of mitral stenosis are double contour of right heart border, straightening of left heart border, and splaying of carinal angle, and Curley's line. Earliest radiological sign of pulmonary venous hypertension in chest X-ray is cephalization of pulmonary vascularity. Earliest feature of pulmonary venous hypertension is upper lobar vessel dilatation. Features of pulmonary venous hypertension are all except uniformly branching lines parallel to pleura. So the features of pulmonary venous hypertension are perihilar haze, peribronchial coughing, upper lobar diversion, and pulmonary ossicles and fine nodular pattern. Chest X-ray picture in congestive cardiac failure is cardiomegaly and thick interlobar septum. All are seen in congestive cardiac failure except prominent lower lobe vessel. So what is seen in congestive cardiac failure? Curly B line and pleural effusion and cardiomegaly. Left heart failure findings are all except oligemic lung field. So left heart failure findings are curly B lines, redistribution of blood vessels to apex, and cardiomegaly. Pruning of pulmonary arteries is seen in pulmonary hypertension. What is not seen on a chest X-ray in pulmonary artery hypertension? Narrowing of central arteries is not seen. What is seen is enlargement of central arteries, peripheral pruning, X-ray picture of ventral septal defect, dilated left atrium, dilated pulmonary arteries. X-ray features of atrial septal defect are all except left atrial enlargement. X-ray feature of ASDR, right atrial enlargement, pulmonary plethora, and small aortic knuckle. What is the objective sign of identifying pulmonary plethora in a chest radiograph? Diameter of the descending right pulmonary artery more than 16 mm. Plethoric lung fields are seen in all of the following conditions except Epstein anomaly. So plethoric lung fields are seen in atrial septal defect, TAPVC, that is total anomalous pulmonary venous connection, and ventricular septal defect. Flask shaped heart is seen in pericardial effusion. Spring water cyst is another name for pleuropericardial cyst. Egg on side appearance on chest x-ray is seen in tricuspid ectasia. Egg in cup appearance is seen in constrictive pericarditis. Snowman appearance on X-ray is seen in which cardiac pathology? Total anomalous pulmonary venous connection. Figure of 8 in chest X-ray is seen in total anomalous pulmonary venous connection, TAPVC.